It's always a great pleasure to give a lecture at a teaching course. This topic is going to be a little bit more difficult than just simply doing the head impulse or head shaking test. And the first question arises, why do you have to do an examination of eye movements in patients who come to you with the dizziness or acute vertigo? And there are two reasons, at least two reasons. First, that's the only way you can reliably differentiate between peripheral and central vertigo. And keep in mind, from a logical point of view, the diagnosis of a central disorder is a diagnosis by falsification of a peripheral vestibular disorder. So this is logical. So you have to look for central signs. Otherwise, you cannot properly differentiate between central and peripheral lesions. This is done by a famous philosopher, Karl Popper, who stated that falsification is possible, verification not. So keep that in mind. We are all logical people. The other thing is, more than 90% of patients with central vestibular lesions do have central ocular motor dysfunction or specific nystagmus, like a downbeat nystagmus. And third, when it comes to central vertigo, keep in mind the key structures are the brainstem, the cerebellum, and connecting pathways. Although we have a central vestibular cortex, this is analogous to the central ocular motor cortex, clinically not really relevant. Second reason, these are yet unpublished data, and since we are neurologists, we are also interested in the cerebellum. And the question arises, what's behind dizziness? And we found out in 5,400 patients from our dizzying units that almost 10% of these patients have clear cerebellar dizziness. That means if you do not properly examine the ocular motor system, you'd miss these patients. You're not correctly diagnosing them. If you go into the details, 20% have cerebellar ataxia, 25% downbeat nystagmus, but 36% they had cerebellar ocular motor dysfunction only. That was the only clinical sign. So you have to properly examine eye movements. And one test had been shown by Michael Halmagyi, visual fixation suppression of the VOR. Topographic anatomy of eye movements. That looks at first glance very complicated. It has to be that complicated because different types of eye movements have to be generated. And the aim of all eye movements is to keep the image of the visual surrounding stable on the retina, to avoid oscillopsia. And this has to be done under different conditions. When I walk around, it's done via the VOR. When I look around, it's done via saccades. When I follow a target, it's done via smooth pursuit. So different conditions require different systems. What is clinically relevant for all of us who deal with patients who suffer from vertigo and dizziness are supranuclear structures, and the next 10 minutes I'm going to talk about them. So structures which generate saccades, which are important for smooth pursuit, which are important for gaze holding function. And the second part of the brain, which is often neglected, is the cerebellum, as you will see later. Now, there are some signs you all know, but maybe you had not been aware that these are typical cerebellar floccular signs. You will leave this session as an expert on cerebellar ocular motor dysfunction, in particular of the flocculus. I promise you. What is the approach?
No. He's looking at you, kid.
So,
No. He's looking at you, kid.
So that's your approach. Just look at the eyes of your patients, and from now on you will correctly diagnose eye movement disorders. Here you see different type of eye movements. What is that? Which type of eye movements? How do you call it? Saccades, horizontal saccades. And these here are analogous vertical saccades. Keep in mind for the rest of your life as a medical doctor, vertical eye movements are generated and controlled in the midbrain, mesencephalon. Horizontal in the pons. Very simple clinical rules. Look here. What's that? Smooth pursuit. Horizontal and vertical smooth pursuit. What is that? Fixation and gaze holding. Gaze holding is very important. Tonight, after 3 whiskey, your gaze holding, your smooth pursuit will be impaired, but not your saccades. You will see. Okay, so to summarize this up, there are different types of eye movements and they have to be systematically examined. First, saccades, very quick eye movements. Smooth pursuit up to 100 degrees per second. Gaze holding is also a function by itself. Divergence eye movements, if they're impaired, they also show a dysfunction in the midbrain. The vestibular ocular reflex we already talked about. The optokinetic nystagmus is a combination of smooth pursuit and saccades. How to examine a patient? Let me have a volunteer. Ooh, someone here. Please. My friend from Scandinavia. Oh, you don't need a bag. Okay, just quickly, 2 minutes. How to demonstrate the examination of eye movements. Okay, first you look into the patient's eyes. What's the next thing you do? If you would like to look for a nystagmus, you have to put on something like that. Then you can easily diagnose peripheral vestibular spontaneous nystagmus. The next thing is you do the cover test, best the alternating cover test, and look for a skew deviation, which you will see in a few moments. Then you can examine smooth pursuit, horizontally and vertically. If you examine vertically downward eye movement, lift your upper, you can do by yourself, both. You use 2 hands, okay? Because otherwise you miss downward eye movements. You will see that later in the video. And saccades, left, right, left, right, left, right. And the final test you can do is, look at that, do a combined head and target movement to look for visual fixation suppression of the VR. So this takes 1 minute and 35 seconds, and you get a good idea about the oculomotor system. That's basically what you have to do to make a correct diagnosis. So now let's look into the details. This looks at first glance a very little complicated, but indeed it's not. We know everything about the oculomotor system. That's a good thing. There are just 5 centers. One is the rostral interstitial nucleus of the MLF. This is the center where vertical saccades are generated. You have burst neurons in these centers. Then we have an analogous structure in the pons. It's a paramedian pontine reticular formation. They are the burst neurons for ipsiversive horizontal saccades. Saccades, vertical, midbrain, horizontal pons. The same is true for gaze holding function. You're all familiar with this term, interstitial nucleus of Cajal. You know that from medical school, but now you know the function. It's the gaze holding center for vertical gaze function, and the analogous structure in the pontomedullary area, it's the nucleus prepositus hypoglossy. It's not normal pressure hydrocephalus. So these are the structures, and the connecting pathway is the posterior commissure. So now look at these 5 patients. What's wrong with the saccades? Diagnosis of eye movements is description. Anything wrong with the saccades? Slow. Okay, where's the site of the lesion? Cerebellum, cortex, midbrain. It's very simple. You know, you end up as real experts, as I promised you. Look, this patient is looking upward. The quick face is beating upward. Maybe upbeat nystagmus. But now look what's happening when it's looking downward. Lift the upper eyelids, it's beating downward. So what is the diagnosis? It's a vertical gaze-evoked nystagmus. Where's the site of the lesion? From the Netherlands. Interstitial nucleus of Cajal. You can make a very precise diagnosis. Now another patient shows up with acute dizziness, and you see that. What type of nystagmus? Mary. What type of nystagmus? Convergence retraction. And this indicates a dysfunction of the posterior commissure. This indicates a dysfunction of the midbrain. So we can make a very specific topographic anatomical diagnosis. And now look at this patient here. This is the second most frequent nystagmus. What is it? Upit. Where's the site of the lesion? This is ambiguous. It's occurring if you have a lesion in the upper midbrain, here, and lower down in the medulla. So now look at this patient here. She has to perform vertical saccades. Can you make a diagnosis? She's blinking. Blinking drives the saccades. So if you do not correctly examine the patient, you will not make a correct diagnosis. Now look here how it looks like. She's suffering from a treatable disorder, which you by no means should miss. And the leading symptom is a vertical saccade palsy. You see, she's performing horizontal saccades to drive the eyes downward. And what is normal is a smooth pursuit. So this is not a chronic progressive external ophthalmoplegia, but it's a very specific sign for a certain disease you'd not miss because you can treat it nowadays. You see, she has not a gaze palsy. She had an isolated vertical supranuclear saccade palsy. Typical. Horizontal is totally normal. You can just take that. You don't need any special device. You see another patient here. Look, are the saccades slower for upward or for downward? Downward. Another specific finding. And now the $2 question. What's the diagnosis? It's Niemann-Pick type C. Do not miss that. Patient come with ataxia. Patient come with a hepatosplenomegaly. Patient might have an untreatable psychosis. So one important differential diagnosis is Niemann-Pick type C, and you should not miss treatable disorders. With miclostate, you can delay the progression of the disease. Therefore, I mentioned that. So, next thing, just a few words. What is a gaze-evoked nystagmus? What is the mechanism? David Robinson, a great engineer, extended our knowledge on the ocular motor system and how to describe it very much because he was an engineer. And a gaze-evoked nystagmus indicates a so-called leaky integrator. You know integration from school? What the brain is doing, if you do a saccade from 0 to 40 degrees, it integrates velocity over time. This ends up with a certain action potential frequency, let's say 100 hertz. This keeps the eyes in an eccentric position. If the integrator is leaky, as you see here on this animation, the eyes drift toward the midline and then they jump back. So a leaky integrator is the mathematical model for a gaze-evoked nystagmus. If this occurs only in the vertical plane, it's interstitial nucleus of Cajal. If it occurs in all directions, as you will see, it's cerebellum. Now look at this patient here. She's performing horizontal saccades. How are they? Slow. Again, you see she's running vertical saccades to drive the horizontal system. Where's the site of the lesion? Michael. Exactly. Paramedian pontine reticular formation, and it's ipsiversive. If you have a unilateral right-sided pontine stroke, the saccades to the right are delayed. Okay, look at this patient here. Acute dizziness. If you see that, you can directly make the diagnosis. It takes 3 seconds. It's a very typical feature of patients with multiple sclerosis, or if patients are beyond the age of 60, of a small lacunar brainstem infarction. You see the horizontal saccades. Is there something wrong? What? They are not conjugate. So, the left eye arrives later than the right eye when she looks to the right. The diagnosis? Internuclear ophthalmoplegia, a typical central sign. You find it in many, many patients with multiple sclerosis, and the reason for that is it affects the medial longitudinal fascicle, which is a long fascicle, which is periventricular, and which is often affected in multiple sclerosis. And the leading symptom is an impairment of adduction, not the dissociated nystagmus. So this is a summary now of the pathological anatomy. If you like, you can take a picture of that. So RIMLF, vertical saccade palsy. INC, vertical gaze-evoked nystagmus. Posterior commissural pathways, convergent retraction nystagmus. MLF lesions lead to an INO. If you go further downward, PPRF, supranuclear center for horizontal saccades, and nucleus prepositus hypoclausy, isolated horizontal gaze-evoked nystagmus. Step 1. Step 2, patient comes with acute vertigo. How do you differentiate peripheral from a central lesion? I call that the big five, and we have already described that in 2008 in the first paper on that. So these are the big five: skew deviation, central fixation nystagmus, saccadic smooth pursuit, gaze-evoked nystagmus in the opposite direction of the spontaneous nystagmus, and acute vertigo and nystagmus with a normal head impulse test. And these are the patients we should be scared of because they look like vestibular neuritis, but this patient had a multiple sclerosis, this one a brainstem encephalitis, and this an incomplete Wallenberg syndrome due to ischemia. How do you examine the patients? First, look at the patient's eyes. And the best thing to do so is the alternating cover test, as you will see in a few moments. The patient has a skew deviation, which you easily can identify by the alternating cover test. So the left eye is below the right eye, which you will see in a few moments. So this is one of the big five. Now the alternating cover test. Very simple, no machines. I fully agree with Michael. We need just our eyes, our brains, and our hand to properly diagnose. Okay? Skew deviation. First, one of the components of the ocular tilt reaction, it indicates a central lesion, and you find it in 30% of all patients with a brainstem lesion. The other components are not specific to differentiate peripheral from central vertigo. There's a simple rule: peripheral and lower brainstem lesion, ipsiversive ocular tilt reaction, upper brainstem lesion above the level of the vestibular nuclei, controversive, and peripheral lesions do have an OTR, but no skew deviation. Michael, how is that related to our topic? No, this one, this gentleman.
No, Nystagmus, no.
Nystagmus. Michael was also falling asleep, therefore I was asking him. Nystagmus comes from the Greek term nystagmus, which means getting drowsy, falling asleep. If you do so, you will make a slow and a quick movement. Which one is the pathological? The slow one. The same is true for nystagmus. The quick one gives the direction of the nystagmus, but the pathological one is the slow one. And now we move over to the next criterion to differentiate peripheral from central, and this is, do you have a peripheral vestibular spontaneous nystagmus or a central fixation nystagmus? First question, what is a spontaneous nystagmus? Going back to the basics. What is a spontaneous nystagmus? It occurs when the subject looking straight ahead. Okay, how do we examine a patient? You have three options: with fixation, and then look for also a gaze-evoked nystagmus, second without fixation, and third with the Dix-Hallpike maneuvers. So here you see a patient fixating, and here with the Frenzel's devices or something else. You see, this subject is able to suppress the nystagmus. And suppression of the nystagmus is a feature of a peripheral vestibular spontaneous nystagmus. You see this able, and now you see. Okay? Peripheral vestibular spontaneous, the clinical feature is suppression by visual fixation. This patient here on the right would like to suppress the nystagmus, but she's not able to do so. The signal which is used to suppress the nystagmus is so-called retinal slip. Here you see a video taken by a special camera which allows you to see the world through the patient's eyes. If you have an isolated peripheral problem, you will be able to use retinal slip to suppress your nystagmus. If you have a central nystagmus, you'd like to use retinal slip, but you are not able to do so. That's the pathophysiological difference. The next thing is to look at smooth pursuit. I'll show you how important it is to examine eye movements to differentiate peripheral from central. You see, this is not smooth, it's saccadic. So saccadic smooth pursuit is number 3 out of 5 as a central sign. The next one is gaze holding. Gaze holding is critical to examine. Patient looks straight ahead. Now you see a nystagmus beating to the left. When he looks to the right, you will see a nystagmus beating to the right. So the key word for you is direction changing nystagmus, because if you examine the patient while looking to the left, this normally leads to an increase of the intensity according to Alexander's law. This will not help to make the diagnosis. But what helps is to examine the patient looking in the opposite direction. So gaze-evoked nystagmus in the opposite direction of a spontaneous nystagmus central sign. And the last thing is acute nystagmus and head impulse test. You see here clearly pathological. And on the right side, a patient with the same history, acute onset of vertigo, acute onset of nystagmus, but a normal head impulse test. So this is one of the big five. To summarize this up, skew deviation, central fixation nystagmus, saccadic smooth pursuit, gaze-evoked nystagmus, and acute vertigo and nystagmus with a normal head impulse test. In 2008, we already published that, putting all these findings together. So that was the first paper on this topic. Unfortunately, it's highly neglected because we did not use a fine acronym for that. Gaze-evoked nystagmus, skew deviation, head impulse, and saccadic smooth pursuit. Sensitivity and specificity were 92%, and all other studies just confirmed these findings. Keep these big five in your mind, and then you can differentiate peripheral from central. Last 5 minutes, cerebellum. Cerebellum is highly neglected. Although the cerebellum contains more neurons than the cortex. Although the cerebellum is a key structure for keeping our balance and for proper eye movements. What is the basic function of the cerebellum? It's like the brake of your car, of your bicycle. Because the only output is inhibition via GABA. What's happening if the brake is not working properly? You move too far. The same can also happen with eye movements. So this is the reason for dysmetria and ataxia. The brake is not working properly. When it comes to eye movements, vertigo, dizziness, and cerebellum, there's just one really important structure, and this is the flocculus, as you will see. Other structures are the vermis and the vestigial nucleus and the nodulus. And please take a photograph of this slide, because it points out how important the cerebellum, in particular the flocculus, is. So a smooth pursuit deficit, an impaired VOR suppression, a gaze-evoked nystagmus in all direction, a downbeat nystagmus, a bound nystagmus, all this can be mainly attributed to the flocculus. All the terms you know from medical school, daily clinical practice, now we can make an exact topographic anatomical diagnosis, and we'll go through that during the next 5 minutes. So look at this patient here. How is her smooth pursuit? Smooth or saccadic? Saccadic. Okay. Where's the site of the lesion? Cortex, brainstem, cerebellum. Cerebellum. Which part of the cerebellum? Flocculus. Which flocculus? The left one. So you can make a very precise diagnosis by just examining eye movements. She also has a gaze-evoked nystagmus, as you see. This gentleman here, what do you see? Bilateral, severe impairment of smooth pursuit. So a bilateral dysfunction of the flocculus. He is suffering, as many other patients, from spinocerebellar ataxia. Now look at this patient here. Is that normal or pathological? This is normal. And now here, another patient. Pathological. More to the left or more to the right? More to the left. Which part of the brain? Flocculus. Left or right? Left. Okay. Steep learning curve for all of you. Okay. So, impaired visual fixation suppression of the VOR indicates a deficit of the smooth pursuit system, because Visual fixation suppression used the same signal, retinal slip, as smooth pursuit, so it goes hand in hand. And specifically, flocculus, paraflocculus. Okay, is anybody aware of a cerebellar nystagmus? There are at least 6 different types. I think there are 10 types. I'm showing not all of them. Cerebellar nystagmus. What is the most frequent one? Gaze-evoked. And the most frequent spontaneous? You'll see it in a few moments. You'd miss it if you do not examine the patient while he or she is looking to the right or to the left. This is enlightening for you. What is the diagnosis? Central, it's downbeat nystagmus. The most frequent nystagmus. How do you treat downbeat nystagmus? Foraminopyridine. Therefore, you should not miss the diagnosis. Okay? So typical patient with downbeat nystagmus. Patient looks to the right. Now to the left, what is it? Gaze-evoked nystagmus. Where's the site of the lesion? Flocculus. Okay? It's boring, but it's true. Okay, so he has a gaze-evoked nystagmus in all directions. Now look at this lady here. She's looking now to the right. She has a gaze-evoked nystagmus to the right. Look what's going to happen when she's looking straight ahead. For a few moments, you will see the term you're all familiar with. It was beating to the right, then it stopped. And now it's beating to the left. It's a rebound nystagmus. So, again, a typical cerebellar sign, sometimes the only sign you have in a patient who shows up with dizziness and postural imbalance. So there are many types of cerebellar nystagmus. Downbeat, gaze-evoked, rebound, central positioning, periodic alternating, and cross-coupling while head shaking. So this all indicates a cerebellar dysfunction. So this is really relevant for your clinical practice. Otherwise, you'd miss a correct diagnosis in about 10% of your dizzy patients. Do a systematic and careful examination, and you're going to be a better doctor. Now look at these patients here. How are the saccades? Hypo or hypermetric? Hypermetric. So again, a typical sign of a cerebellar dysfunction analogous to limb ataxia. And now a very rare patient. Look what she's having and what she's suffering from. How are these saccades? Hypometric. That's very rare. Nevertheless, I show it because it fits very well into the anatomy of the oculomotor system. So, statement number 1. The cerebellum determines the accuracy and not the velocity of saccades. This explains why you can have hypermetric saccades if there's a lesion of the vestigial nucleus, and hypometric saccades if there's a lesion of the dorsal vermis. So dorsal vermis leads to hypometric saccades because this leads to a disinhibition of the vestigial nucleus. So very precise, clear, functional anatomy of the oculomotor system. To summarize that up, flocculus, smooth pursuit, impaired VOR suppression, gaze-evoked nystagmus, downbeat and rebound nystagmus, vermis and vestigial nucleus, dysmetric saccades, and the nodulus, central positioning nystagmus, and periodic alternating nystagmus. And once again, we just summarized these findings here, presented it on a poster at the ERN meeting. So about 10% of patients with dizziness have a cerebellar dizziness. And the key to the diagnosis is examine the eye movements, and then you make a correct diagnosis. Here again, if you'd like to take a picture, you are delighted to do so. This shows a complete examination, how to examine the vestibular and the oculomotor system, and in green, the big 5 to differentiate peripheral from central. And those who are more interested in the topic, there's a new website. It's called www.neurocular.com. You see about 120 videos with the correlation between clinical examination findings and precise topographic anatomical diagnosis. I know this has been quite intense. In your position, I'd have to listen to the lecture 7 times to remember some of the parts, very little. Thank you for your kind attention, and I think you dearly deserve the break we are going to have now. But maybe there are some questions.